Imagine this. You're a first-year nursing student, maybe like Kelly Johnson in our source material, and you're caring for Mrs. Stein, who's 86. She's just had hip surgery.
Okay.
She's in quite a bit of pain, doesn't really want to move, and then you spot some drainage on her gown.
Uh-huh.
What do you do? Like, what are you even looking for right then?
Yeah, that's a classic scenario, isn't it? Really throws you in the deep end.
Exactly. And it shows why understanding skin integrity and wound care is just so critical in nursing. It's fundamental.
Absolutely. Everywhere. Hospitals, clinics, home care. Skin health is always a priority.
So our mission today on the deep dive is to take all that vital info from the Fundamentals of Nursing chapter on skin integrity and wound care
Very text, yeah.
and really break it down for you, our listeners, especially if you're prepping for your nursing career, maybe studying for the NCLEX.
And I'm happy to be here to help connect that book knowledge to what you actually do and see in practice.
Fantastic. Let's dive in. Okay, so foundations first. Let's talk about the skin itself, the basics.
Right. It's fascinating, really, how it works. You've got two main layers. There's the epidermis, that's the thin outer one.
Our first line of defense.
Exactly. Protects us from dehydration, chemicals, all sorts. And it's always renewing itself. Then underneath, you have the dermis.
That's the thicker layer.
Yeah, that's where the strength is. It's full of collagen, blood vessels, nerves. It gives the skin its structure. When you get injured, the epidermis tries to resurface quickly, and the dermis works on restoring that structure.
Okay. But you mentioned Mrs. Stein is 86. How does aging affect this? I mean, if our skin changes, what does that mean for nursing care? Like, even for something basic, like taking off tape?
Oh, that's such a practical, important point. Big impact. As we age, skin loses elasticity, gets less stretchy, collagen decreases, the tissues underneath, muscle and fat, they thin out.
So it's more fragile.
Much more fragile. That connection between the epidermis and dermis flattens out, making it super easy to tear the skin. So for tape, here's the key trick. Always gently release the skin from the tape.
What do you mean?
You sort of push the skin away from the adhesive rather than just ripping the tape off the skin.
Okay. Push the skin, don't pull the tape.
Exactly. It prevents countless skin tears. A small thing, but huge for older adults like Mrs. Stein.
That's a great practical tip. Okay, now, something nurses see constantly. Pressure injuries, what are they exactly? And I hear the name changed.
Yeah, the terminology shifted from pressure ulcer to pressure injury because it's not always an open ulcer, you see. It's localized damage to the skin and the soft tissue underneath.
Usually over a bony bit.
Often, yeah. Or sometimes it's caused by a medical device pressing on the skin. It can look like intact skin, maybe a blister or an open wound.
And it's caused by pressure.
Right. Intense pressure or pressure that lasts a long time, sometimes combined with shear. We think about it as either top-down damage that's more superficial from shear or friction, or bottom-up, which is deeper damage from that sustained pressure cutting off blood flow.
So what's happening like inside the tissues when that pressure hits?
Well, think about tiny blood vessels, the capillaries. If the external pressure gets higher than the pressure inside those capillaries, we call it capillary closing pressure, around 15 to 32 millimeters of mercury.
Which isn't very high.
Not at all.
Yeah.
If you exceed that, it's like pinching the hose. Blood flow gets reduced or cut off completely. No oxygen, no nutrients. That's ischemia.
And if that lasts too long...
Tissue damage. Tissue death, eventually.
Yeah.
That's why moving patients relieving pressure is absolutely non-negotiable.
Okay, so when you relieve the pressure, the skin gets red. Hyperemia.
Right. Blood rushes back in.
Now here's the really interesting bit for nurses on the floor. You press on that red spot. If it doesn't turn white and then back to red, what does that mean?
That's the critical difference. If it blanches, turns white, and then red again quickly, that's usually okay. Just reactive hyperemia, the body responding normally.
But if it stays red, doesn't blanch.
That's your big red flag. We call it nonblanchable erythema. It tells you there's likely damage deeper down in the tissues, and that right there is a stage 1 pressure injury.
Okay, that seems clear enough for lighter skin tones. But what about assessing patients with darkly pigmented skin? Blanching might not be obvious.
It's definitely a challenge, and something nurses really need to be skilled at. You're right. Blanching often isn't visible, so you have to rely on other cues.
Like what?
Compare the area to the skin right next to it. Feel for changes in temperature. It might feel warmer initially due to inflammation, then cooler as tissue starts to die.
Okay. Temperature. What else?
Feel the tissue consistency. Does it feel different? Maybe firmer or kind of boggy or mushy compared to the surrounding skin? Is there subepidermal moisture? And always Always ask the patient if they have any pain or discomfort in that area.
And the color might look different too.
Yes, instead of bright red, it might look purple or deep red or violet,
Yep.
or even bluish in darker skin. Need sharp assessment skills.
Let's connect this back to Mrs. Stein. Why is she so high risk? What are the big risk factors here?
Well, Mrs. Stein has several. First, her age, we know older skin is more vulnerable. Second, her hip surgery and the resulting pain mean decreased mobility. She's not moving much.
And when she does move, maybe sliding down in bed.
Exactly, that increases shear. Plus, she has type 2 diabetes, which impacts circulation and how well wounds heal. Other big risk factors are things like impaired sensory perception. Maybe someone can't feel the pressure building up.
Like with a spinal cord injury?
Right, or incontinence, poor nutrition, being critically ill. Lots of things put patients at risk. The key is identifying that risk early.
You mentioned shear. Can you clarify the difference between shear and friction? They sound similar.
They do, but they're different forces. Shear is that sliding motion. Picture the patient whose head of the bed is raised. They slide down, but their skin kind of sticks to the sheets while their bones move down.
Ah, okay, like an internal sliding.
Precisely. And it causes damage deep in the tissues, often leading to undermining where the wound gets bigger under the skin surface.
When
Friction is more superficial. It's the skin being dragged across a rough surface, like the bed sheets. Think sheet burn. It's red, painful, damages the top layer, but it's not technically a pressure injury.
Got it. What about moisture? How does that fit in?
Moisture is a big problem, too. Prolonged wetness from wound drainage, urine, stool, sweat. It softens the skin, makes it less resistant to pressure, shear, and friction. We call that moisture-associated skin damage, or MASD.
So it's not pressure, but it makes pressure worse.
Exactly. It weakens the skin's defenses.
Okay, this is crucial for practice. The pressure injury staging system. Can you walk us through the stages? What do they look like?
Absolutely. This is the NPIEP system. Stage 1. Skin's intact, but you see that non-blanchable redness we talked about. Or in darker skin, maybe those color changes, warmth, or hardness.
Okay, skin's red but not broken.
Right. Stage 2. Now the skin is broken. It's partial thickness loss, meaning you can see the dermis. The wound bed looks pink or red. It's moist. It might look like a shallow crater or maybe an intact or ruptured blister filled with serum. Critically, you don't see fat here.
No fat yet. Got it. Stage 3.
Stage 3. This is full thickness skin loss. Now you can see the adipose tissue, the fat. You might see granulation tissue, which is good, but also maybe some slough, that yellowish stringy stuff, or eschar, the black or brown dead tissue.
Can it tunnel under the skin?
Yes, undermining and tunneling can happen in stage 3, but you don't see muscle or bone.
Okay. Stage 4.
Stage 4. This is the deepest, full thickness skin and tissue loss. You can actually see or directly feel fascia, muscle, tendon, ligament, cartilage, or even bone. Slough and eschar are often present, and undermining tunneling are common.
Wow. Okay, are there others?
Yes, 2 important ones. Unstageable. This is when you can't see the true depth because it's covered by too much slough or eschar. You have to remove that dead tissue first to stage it properly.
Makes sense. You can't see the bottom.
Exactly. And finally, deep tissue pressure injury, or DTPI. This one looks like a deep bruise, persistent, non-blanchable, deep red, maroon, or purple area. Or it might be a blood-filled blister. The skin might be intact or not.
And this comes from deep pressure.
Often from intense pressure or shear, right down at the bone-muscle interface. It can deteriorate really rapidly into a stage 3 or 4.
Okay, that clarifies the stages. Now, a question that often trips students up. Why does a pressure injury, say a stage 3, always stay a healing stage 3? Why doesn't it become a stage 2 or 1 as it gets better?
Yes. That's a key concept. It's because the tissue that was lost doesn't regenerate perfectly. A stage 3 injury lost skin and fat. As it heals, it fills in with granulation tissue and eventually scar tissue.
It's not growing back the original layers.
Exactly. It's filling the hole with different materials. So while it's healing, the history of the wound, the maximum depth it reached, is still stage 3. We call it a healing stage 3 to show progress, but it doesn't reverse stage.
That makes so much sense. Okay, quickly, what about injuries from medical devices or adhesives?
Right. MDRPI, medical device-related pressure injury. Think oxygen tubing behind the ears, casts, splints, anything pressing on the skin. Nurses need to check under and around devices frequently.
And MARSI.
Medical adhesive-related skin injury. That's damage from tape or dressings being removed, redness, blisters, tears. Goes back to that gentle removal technique we talked about.
Okay, we understand the injuries. Now, how do wounds actually heal? Let's start with classifications. Acute versus chronic.
Right. We generally divide wounds into 2 types based on how they heal. Acute wounds. These are the ones that heal as expected in an orderly time frame. Think of a clean surgical cut or a simple scrape. The edges are usually neat, they close up nicely,
Oh, predictable healing.
pretty much. Chronic wounds. These are the tricky ones. They fail to heal in that orderly way, maybe due to underlying issues like poor blood flow, infection, or just repeated injury to the same spot.
Like a pressure injury that just weren't closed.
Exactly. Or a diabetic foot ulcer. They take much longer, higher risk of complications.
And what about healing by intention? Primary, secondary.
Ah, yes. This describes how the wound closes. Primary intention. This is for clean wounds with minimal tissue loss, like that surgical incision we mentioned. The edges are brought together, approximated maybe with stitches or staples. It heals fast, mainly by skin cells growing across, minimal scarring.
Okay, edges together.
Secondary intention. This is for wounds where there's significant tissue loss, like a burn or maybe a stage 2 pressure injury, or if the wound is infected. These are left open.
Open.
They need to heal from the bottom up. The body fills the space with granulation tissue, then the wound edges contract, and finally skin cells migrate across the top. Takes longer, bigger scar, higher infection risk.
Got it. Bottom-up healing. Is there a tertiary?
Yes, tertiary intention. Less common. It's like a delayed primary closure. The wound is left open for a few days, maybe to let drainage out or watch for infection, and then it's closed surgically.
Okay. Let's break down the actual steps, the phases of repair.
Okay, for partial thickness wounds, remember, just the epidermis and maybe top of the dermis is simply. You get an inflammatory response, then new skin cells multiply and migrate across the wound bed.
They crawl across?
Kind of. And here's a key thing. They migrate much faster across a moist surface. That's why keeping these wounds moist helps them heal quicker. Then the layers rebuild.
Makes sense. What about deeper, full-thickness wounds?
That's a more complex 4-phase process. 1. Hemostasis happens immediately. Stop the bleeding. Blood vessels constrict, platelets rush in and form a plug, and a fibrin clot forms, like a natural bandage.
Step 1, stop bleeding.
Right. 2. Inflammatory phase. The body's cleanup crew arrives. Damaged cells release signals, causing redness, warmth, swelling. White blood cells flood the area, first neutrophils, then macrophages.
The garbage cells?
Exactly. They eat bacteria and debris, cleaning the wound bed so healing can start. This usually lasts a few days.
Okay, cleanup. Phase 3.
3. Proliferation phase. This is the rebuilding phase. Starts maybe 3-4 days after injury, can last a couple of weeks. The wound starts filling in with that bright red, bumpy granulation tissue.
That's the good stuff.
Yes, it's new connective tissue and tiny blood vessels. The wound also starts to contract, getting smaller. New collagen is laid down. Skin cells start migrating across the granulation tissue bed.
Rebuilding. And the final phase.
4. Remodeling and maturation. This takes the longest weeks, months, even a year or more. The collagen that was laid down gets reorganized and stronger. The scar forms and matures. But important note, the scar tissue never reaches the full strength of the original skin, maybe 80% at best.
Wow, okay. Even when it looks healed, it's not quite the same. Now, what can go wrong? What are common complications?
Several big ones nurses need to watch for. Hemorrhage. Bleeding. Could be right after the injury or surgery or delayed. Can be obvious external bleeding, soaking dressings, or internal.
How would you know if it's internal?
You might see swelling or distension around the wound, maybe increased drainage in a surgical drain, or signs of hypovolemic shock, low blood pressure, high heart rate. A collection of blood under the skin is a hematoma.
Okay, bleeding. What else?
Infection. Huge risk, especially with chronic wounds or surgical sites. Look for local signs. Increased redness spreading out, more drainage. Maybe the drainage changes color or smells bad.
Like purulent drainage, that thick yellow-green stuff.
Exactly. Also warmth, pain, swelling around the wound. Systemic signs include fever, chills, high white blood cell count. Surgical site infections, SSIs, are a major concern.
Infection. Okay, next.
Dehiscence. This is when a wound, usually a surgical incision, partially or totally separates. The layers come apart.
When does that usually happen?
Often between 3 to 11 days after surgery. Patients might say they felt something give way or pop. You might see a sudden increase in serosanguineous drainage, that watery pinkish stuff.
That sounds scary. Is there something worse?
Yes. Evisceration. This is dehiscence taken to the extreme. The wound separates completely, and internal organs actually protrude out.
Oh, wow. That's an emergency.
Absolute emergency. If you see this, your immediate actions are critical. Cover the protruding organs with sterile gauze soaked in sterile saline. Keep them moist.
Don't try to push them back in.
Never try to push them back in. Keep the patient MPO nothing by mouth. Monitor vital signs closely for shock. Position them with knees bent slightly if possible to reduce abdominal tension. And notify the surgeon immediately. Prepare for emergency surgery.
Got it. Cover, keep moist, MPO, monitor. call for help.
Okay, evisceration, definitely something to be prepared for. This all highlights the nurse's crucial role. How does clinical judgment tie into all this?
It's everything, really. From that very first assessment, figuring out risks, deciding which interventions are needed, seeing if they're working, nurses are constantly using critical thinking. It's not just following steps, it's understanding the why and adapting to the individual patient. Let's go back to Mrs. Stein. How would a nurse like Kelly put this all together in her assessment?
Well, first, on admission, Kelly would use a risk assessment tool, probably the Braden Scale. It looks at things like sensory perception, moisture, activity, mobility, nutrition, friction, and shear.
And Mrs. Stein would score low, meaning high risk.
Likely, yes. Her age, her limited mobility from the hip surgery, her diabetes, those all put her at high risk. That flags her for close monitoring right away.
Okay, risk assessment first. Then what?
Then talking to Mrs. Stein, assessing through the patient's eyes. What are her concerns, her understanding? Remember, she was scared of moving because of pain, rated it 8 out of 10, and worried about pain meds.
Right, fear of addiction.
So Kelly didn't just ignore that. She listened, explained why pain control was important for healing and getting mobile, and timed the analgesic, giving it 30 minutes before PT so it would be working best.
Patient-centered care right there.
Exactly. It directly impacted Mrs. Stein's ability to participate, which helps her skin.
So after the risk assessment and patient interview comes the hands-on skin and wound assessment. How often and what are you looking for?
Frequency depends on risk, but at least once per shift. High-risk patients, maybe every 4 hours. You're using sight and touch, checking those bony spots, sacrum, heels, elbows, hips. Looking for redness, is it blanchable or non-blanchable?
And for darker skin.
Remembering those other cues? Temperature changes, tissue consistency, firm or boggy, any pain reported by the patient. Color changes like purple or maroon.
Okay. If there is a wound, what do you assess?
You look at the wound bed itself. What kind of tissue is there? Healthy granulation tissue, that nice red, moist look? Or is there slough or eschar that needs removing? Then you measure length, width, depth. Use a disposable ruler for length and width, and a sterile cotton-tipped applicator gently inserted to find the depth. Tracking measurements shows if it's healing or getting worse.
What about drainage?
Assess the exudate, yes. Minimal, moderate, copious. Sometimes you estimate based on dressing saturation. 1 gram of drainage roughly equals 1 ml. Then color and consistency, cirrhosis, clear, watery, sanguineous, bloody, serosanguineous, pinkish, purulent, thick, colored, maybe odorous. And note any odor.
And the skin around the wound?
Yes, the peri-wound skin. Is it intact, red, macerated, waterlogged, dry, irritated? You also check any drains. What type? Is it secure? What's the drainage look like? Is it patent? And if infection's suspected, you might need to get a wound culture, usually after cleaning the wound first.
Beyond the wound itself, what other factors are important in the assessment? Systemic things.
Absolutely. Nutrition is huge. You can't build tissue without protein, vitamins, minerals. Prealbumin levels can give a good snapshot of recent protein intake.
What else?
Body fluids, urine, stool, gastric juices, they can be really harsh on the skin if there's incontinence or leakage. And pain. As we saw with Mrs. Stein, uncontrolled pain stops people from moving, increases pressure risk, and just generally hinders healing.
Okay, comprehensive assessment done. Now, planning care. How does that work? Involving the team.
Your assessment leads to nursing diagnoses like impaired skin integrity, risk for infection, impaired mobility. These help you set priorities. For Mrs. Stein, managing pain and boosting mobility were top priorities because they directly impacted her skin risk.
And teamwork.
Essential. You're often working with wound care nurse specialists, dietitians for nutritional support, physical therapists for mobility, just like Kelly did with Mrs. Stein, coordinating that pain med before PT. That's planned collaboration.
Right. Let's get practical. What are the key interventions nurses perform? Starting with prevention.
Okay, pressure injury prevention, skin care. Gentle cleansing, no harsh soaps, no super hot water. Use moisturizers to keep skin hydrated. If there's incontinence, meticulous hygiene is key. Plus, using a moisture barrier ointment or cream to protect the skin.
Okay, keep skin clean and protected. Positioning.
Positioning. Turn and reposition patients frequently, at least every 2 hours in bed, maybe more often if high risk. Use the 30-degree lateral tilt position to keep pressure off the hip bone. When moving patients, lift, don't drag, to avoid shear and friction.
And the head of the bed.
Keep it at 30 degrees or lower if possible to reduce sliding down. If someone's in a chair, teach them or help them shift their weight every 15 minutes. Very important. Never massage reddened, bony areas. It can actually cause more damage underneath.
Good point. What about special beds?
Support surfaces. Therapeutic beds and mattresses can help redistribute pressure. They don't replace turning, but they add another layer of protection for high-risk patients.
Okay, that's prevention. Now, managing existing wounds.
Wound management. The big principle is maintaining a moist wound environment. Remember how those skin cells migrate better.
Right, so how do you clean wounds?
Use non-cytotoxic cleaners, like normal saline, for most clean wounds. Avoid things like hydrogen peroxide, povidone iodine, or Datkins solution on healthy granulation tissue because they can actually harm healing cells. Sometimes you need to irrigate the wound using gentle pressure, like with a 35 mmL syringe and a 19-gauge angiocatheter, to flush out debris. Flow from least contaminated area to most contaminated.
What if there's dead tissue, slough, or eschar?
Then you need debridement, removing that non-viable tissue so healing can occur. There are different methods: autolytic, using the body's own enzymes with certain dressings; mechanical, like wet to dry, though less common now, or irrigation; chemical, using enzymes; or surgical, sharp debridement by a trained provider. Always manage pain before any debridement procedure.
Okay, and dressings, there are so many types.
Dressings have many functions: protect from contamination, absorb drainage, maintain moisture, provide medication. The choice depends entirely on the wound, its stage, depth, amount of drainage, presence of infection, tissue type.
Can you give a couple of examples?
Sure. Transparent films are good for superficial wounds like stage 1 or 2, or to cover IV sites. They let you see the wound but keep it moist. Hydrocolloids form a gel when they absorb drainage, good for stage 2 or shallow stage 3, with minimal to moderate exudate. Hydrogels actually donate moisture, so they're great for dry wounds or painful wounds. There are many others: foams, alginates, composites. Table 48.dead in the text is a great resource for matching dressings to wounds.
And changing dressings, any key tips?
Use the right technique, clean or sterile depending on the wound. Remove tape carefully. Remember MARSI? Pull parallel to the skin, push the skin away. For patients needing frequent changes, consider Montgomery ties straps that lace up across the dressing so you don't keep ripping tape off fragile skin. And a common mistake: don't pack wounds too tightly. It can impair circulation within the wound bed.
Good to know. What about that VAC therapy?
All right, negative pressure wound therapy, NPWT, often called VAC therapy. It uses a special dressing, seals it, and applies controlled suction.
What does that do?
It helps pull out excess drainage, reduces edema, promotes blood flow, and encourages granulation tissue formation. Used for acute and chronic wounds, grafts, flaps. It's quite effective for many complex wounds.
And always, comfort measures.
Always. Pain medication 30-60 minutes before dressing changes or debridement makes a huge difference for the patient.
What about heat and cold therapy? How does that fit in?
They can be useful adjuncts. Heat causes vasodilation, opens up blood vessels, improves blood flow, relaxes muscles, good for stiffness, some types of pain. Cold causes vasoconstriction, narrows vessels, reduces inflammation, swelling, and numbs nerve endings. Good for acute injuries like sprains or immediately after surgery to reduce swelling and pain.
Any safety rules for heat and cold?
Absolutely crucial. Always protect the skin with a barrier, like a towel. Check the skin frequently, maybe every 20 minutes, for redness, blistering, or paleness. Never let the patient adjust the temperature themselves. And know the contraindications, like don't put heat on an area that's actively bleeding, or cold on someone with poor circulation like peripheral vascular disease. Box 48.12 covers safety guidelines well.
And lastly, binders and bandages.
They provide support, like an abdominal binder after surgery. They can immobilize a joint, secure a dressing, reduce swelling, like grabbing an ankle, or even apply pressure to stop bleeding. Proper application is key, not too tight to cut off circulation, ensuring comfort, using the correct wrapping technique like spiral or figure 8 for limbs.
We've covered a huge amount, from assessment to all these interventions. How do we tie it all together with evaluation? How do we know if our care is working?
Evaluation is constant, really. It's not just something you do at the end. Are the interventions meeting the goals we set? Is the patient progressing as expected?
And involving the patient is key.
Definitely. Connecting this to the bigger picture. Evaluation isn't just ticking boxes. It's about seeing if our care is genuinely making a difference in that patient's healing and their quality of life. We need to ask them, observe them.
So with Mrs. Stein, how did Kelly evaluate the care?
Well, Kelly checked back with Mrs. Stein about her pain. Mrs. Stein reported it was much better, down to a 2 or 3 out of 10, and she felt comfortable with a non-opioid approach.
That's a great outcome.
Yes, and Kelly observed Mrs. Stein moving more, participating actively in physical therapy. Then assessing the skin. The sacral redness had decreased, and that stage 2 pressure injury on her hip It was smaller, less drainage, showing clear signs of healing reepithelialization starting around the edges.
So the interventions were working.
Exactly. Those are measurable signs that the plan was effective.
What if things aren't going as planned? How do you recognize that?
You have to be looking for unexpected outcomes, too.
Mm.
Is the pain getting worse instead of better? Is the wound looking worse, bigger, more drainage, bad odor? Are there new signs of infection?
And if you see those,
Then you need to act. Reassess everything. Maybe the wound needs a different dressing. Maybe nutrition needs adjustment. Maybe an infection is brewing. You'd notify the provider, maybe get orders for a wound culture or labs, and definitely adjust the care plan. Nursing care isn't static. You're always assessing and adapting.
this deep dive really highlights how complex something we might think of as simple skincare actually is. It takes so much knowledge and judgment.
It really does.
It almost makes you wonder, if skin integrity demands this level of meticulous attention, what other fundamental aspects of patient care might we sometimes overlook or underestimate in our daily practice that could have a really profound impact?
That's a great thought to leave with. It's about seeing the whole picture, always questioning, always learning, mastering these fundamentals like skin and wound care. It's challenging, but incredibly rewarding. It builds that critical thinking muscle you need as a nurse.
Well, thank you so much for sharing your expertise today. And to you, our listeners, thank you for joining us on the deep dive. We, the Last Minute Lecture team, hope this exploration of skin integrity and wound care empowers you in your studies and your future practice. Keep learning, stay curious, and know you're part of a community making a real difference.